Welcome all. We continue with carcinoma of vulva, and here we are going to discuss about the management. Okay, first session we have seen about the pathogenesis. We have seen about the staging of the carcinoma of vulva, and here we will discuss about the management, different types of surgery and different modalities. The most commonly asked questions on this particular topic will be surgical management of the carcinoma of vulva. You may be asked about the inguinofemoral lymphadenectomy, discuss the sentinel lymph node biopsy in carcinoma of vulva, describe stage-wise management of the carcinoma of vulva, discuss the role of radiotherapy in vulval cancer. Then short notes, there may be sentinel lymph node biopsy, groin node dissection, radical vulvectomy, radical local excision, surgical margins, maybe a viva question, reconstruction after vulvectomy, prognostic factors, and lymphedema. Okay, lymphedema. Then what we are going to discuss today about the histology of various malignancies of the vulva, then principles of the management. Whichever surgery you perform or you talk about, you should know the principles of that particular surgery. Okay. Then groin node management, sentinel lymph node biopsy, radiotherapy, chemotherapy, and stage-wise management. That is what we will be discussing. Now coming to the WHO histological types. What are the different histopathological types of carcinoma of vulva? Most common, more than 90%, it is a squamous cell carcinoma. Melanoma around 5 to 7%. Basal cell carcinoma is less than 2%, and others are rare. That is Bartholin's gland carcinoma, adenocarcinoma, Paget's disease with invasion, sarcoma. These are rare. So commonest, more than 90%, squamous cell carcinoma. Melanoma 5 to 7%. Basal cell carcinoma less than 2%. Okay, so squamous cell carcinoma is the most common histological type of vulval cancer. Last session we have discussed about variants of squamous cell carcinoma. One which is HPV associated, it is a either basilar squamous cell carcinoma or warty squamous cell carcinoma. HPV independent is a keratinizing squamous cell carcinoma. Okay, histologically you have grades, that is grade 1, grade 2, and grade 3. Grade 1 is a well differentiated, grade 2 is a moderately differentiated, grade 3 is a poorly differentiated. In any malignancy, when we discuss, we should know what are the poor prognostic features for that particular malignancy. This we have seen with the CS cervix also. So poor prognostic histological features for CS vulva. One, positive lymph nodes. Second, lymphovascular space invasion, deep stromal invasion. Margins are positive. Then extracapsular nodal spread and large tumor size. So these are the poor prognostic histological features for vulval malignancy. Okay, what are the principles of management? On which factors the treatment will be decided? So there are disease related factor and there are patient related factor. So disease related factor, one is a staging, FIGO staging. Then second is the size of the tumor. Third is the site of the lesion. Fourth is what is the histopathological type. Then depth of stromal invasion, the number of positive lymph nodes, and extracapsular spread. So these are the disease related factors like FIGO staging, tumor size, site of the tumor. We have discussed whether it is medial, lateral, then size of the tumor. Then histological type, depth of stromal invasion, number of positive lymph nodes, and extracapsular spread. Patient related factors such as age, fitness of the patient, comorbidities, sexual function, reconstruction requirement, and the patient preference. So these are the factors on which your treatment modality will depend. So what are the modalities which are available? Surgery, and that is the mainstay of the treatment for CS vulva. Then another is radiotherapy, concurrent chemoradiation, chemotherapy in selected cases, and palliative treatment if the disease is very much advanced. Okay, surgical principles you have to know and you should write first when you are talking about the treatment for CA vulva. What is our goal? Goal is complete excision. Okay, that is R0 resection. Okay, goal is a complete tumor excision. So it is not the only lesion you have to excise, but it has to be associated with the adequate pathological margin. Now, what is that adequate pathological margin? Listen to the session carefully. Okay, then appropriate groin node assessment. Now, what do we mean by appropriate groin node assessment? First, whether lymph node dissection is required or not. Second, if it is required, then whether it is unilateral or bilateral. Okay, so complete tumor excision, adequate pathological margins, appropriate groin node assessment, and second is the preservation of the function wherever feasible. So these are main goals for the treatment when we are dealing with the CA vulva. So In olden days, when you diagnose the CA vulva, CA cervix, radical hysterectomy, here radical vulvectomy. But there is no such dictum now. So routine radical vulvectomy for every patient is wrong. It is not justified. Okay. So CA vulva does not mean the radical vulvectomy for all patients. Okay. It is the individualized surgery. And what are the different types of surgery? One is a wide local excision. Second, radical local excision. Third is a radical partial vulvectomy. Fourth is a radical vulvectomy in selected cases. Okay. So we should know what exactly these terminologies mean. Okay. So modern practice favors conservative surgery with adequate oncological margins, minimizing the morbidity while maintaining the local control. Okay. So these are the few important things which you should understand. So let us see first the wide local excision. What do we mean by the wide local excision? It is the removal of tumor with surrounding normal tissue. So we are going to do the excision of the tumor with adequate margin. Surrounding normal tissue also you have to remove, and indication is a small localized invasive lesion, selected stage 1, especially 1A. Okay, we have seen stage 1 is divided into 1A and 1B. Okay, so when you have a small localized invasive lesion and a selected stage 1 disease, so here how much margin you have to remove beyond the tumor? So we have to aim for more than 1 centimeter or equal to 1 centimeter gross margin, so that when you put the tissue in the formalin, there will be shrinkage of this particular tissue, giving at least 8 millimeter histological margin after the shrinkage. So histologically, you should get the at least 8 millimeter margin. Then you say that this is a adequate and this is wide local excision. Okay, to say otherwise this is not wide local excision. Okay, so you have removed it completely, but if the margin is less than 8 millimeter histologically, or to get histological 8 millimeter, you need to remove surgically more than 1 centimeter margin. Okay, second operative is a radical local excision. So what does radical local excision includes? It includes the removal of the tumor, full thickness vulvar tissue and deep fascia. Okay, it is preferred for early invasive lesions. Okay, so if it is a 1B, then onwards to you may go for radical local excision. So 1A disease, you will go for wide local excision. Okay, then you have a radical local excision where there is a difference between the wide local excision and radical local. Here also tumor is removed, here also adequate margin is removed, but the depth differs up to the full thickness and including the deep fascia. This is the radical local excision. Okay, then next is a radical partial vulvectomy. It is the removal of the part of the vulva, deep tissue along with adequate margin, used when the tumor is larger but confined to the one side. Okay, so in that particular case, you will go for partial vulvectomy, and for that the tumor should be larger but confined to the one side. Next is a radical vulvectomy. Okay, so removal of the entire vulva along with deeper tissue. The indications for radical vulvectomy: when you have an extensive multifocal disease, large central tumor, and selected advanced lesions. Okay, nowadays this is performed less frequently. Okay, adequate surgical margin. Ideal margin is a histological margin more than or equal to 8 millimeter is the ideal. Okay, if margins are close or positive, then you will have to go for re-excision. Okay, if feasible, you go for re-excision if you do not get 8 millimeters of the histological margin. Okay, or what you can do, you go for adjuvant radiotherapy if re-excision is not appropriate or margins remain positive. You excise, but if it is still positive, then you go for adjuvant radiotherapy. Okay, now this is about the lesion. Now, what about the groin node management? So there are two things. One, you have to remove the node, and second, we have to talk about the what you are going to do with the groin node management. Okay, so stage 1A you do not require, you just have to do the wide local excision, but from there onwards, at least sentinel lymph nodes you have to sample, and depending upon the sentinel lymph node finding, you will go for dissection. Okay, so groin node management, most important prognostic factor is the lymph node status. Indications for the groin node assessment: it is required when the invasive, invasion is stromal invasion is more than 1 millimeter. That means when it is 1B or more, you have to know the lymph node status. Okay, So if the lesion is a lateral lesion, that is the lesion is more than 2 centimeter from the midline, you will go for ipsilateral groin assessment. So if this is the midline and if the lesion is within 2 centimeter of the midline, in that particular case, you will go for bilateral. But if the lesion is beyond 2 centimeter, then ipsilateral groin assessment you will do. Okay. So midline lesion within 2 centimeter, then you will go for bilateral groin assessment. Okay. So inguinofemoral lymphadenectomy. So it will remove the superficial inguinal lymph nodes, deep inguinal lymph nodes, and indications for the inguinofemoral lymphadenectomy are: one, if you get a clinically positive nodes, you have got a vulval lesion and clinically also there are inguinal lymph nodes, or clinically there are no nodes, but on investigation you get the nodes. Sometimes you do the sentinel lymph nodes and it becomes positive, then also you will have to do the lymphadenectomy. Sometimes sentinel lymph node assessment is not possible, or it is not suitable. In that particular case, you will directly go for lymphadenectomy. Large tumors, you need not do the sentinel node assessment, you directly go for lymphadenectomy. And if it is a multifocal disease, then you will go for lymphadenectomy. Remember, multifocal disease, you don't go for multifocal disease. It is always better to go for lymphadenectomy rather than assessment. Okay. So what are the complications? There may be hemorrhage, seroma, wound infection, skin flap necrosis, etc. Late complications such as lymphadenoma, lymphocyst, chronic pain, cellulitis. Okay. So lymphadenoma is the most or the commonest long-term complication for this, for the groin node dissection. Okay. Now, sentinel lymph node biopsy, SLNB. Okay, so SLNB has become the preferred nodal assessment for carefully selected early stage vulvar cancer. Okay, so what is the principle? Identify the first draining lymph node. If it is negative, remaining nodes are likely to be negative. So what we will do, we will identify the first draining lymph nodes. If it is negative, the remaining nodes are unlikely to be affected. Okay, what is the advantage? It reduces the morbidity, less lymphedema, then less wound breakdown, shorter hospital stay. Then what are the indications for sentinel lymph node biopsy? Okay, so to go for sentinel lymph node biopsy, it is better to have unifocal tumor. Okay, and all should be present. Remember, when you want to go ahead with the sentinel lymph node biopsy, all should be present. Okay, like unifocal tumor, the tumor size should be less than 4 centimeter. Clinically node negative, so clinically you should not have any node which are palpable. No previous groin surgery, no suspicious nodes on imaging or clinical examination. Okay, so these are the indications, and you should satisfy these particular criteria to go for SLNB. What are the contraindications? If it is a multifocal disease, clinically positive groin nodes, large tumor, previous groin dissection, that is an contraindication for the SLNB. Okay, so technique, radioisotope, blue dye, or you can go for combined technique. Okay, now if the sentinel node is positive, then what will you do? So management will depend upon the size of the metastasis, number of the involved nodes, and current institutional protocol. So option, you go for inguinofemoral lymphadenectomy or groin radiotherapy in selected low volume nodal disease. Okay, so you can go surgically for inguinofemoral lymphadenectomy, or you go for groin radiotherapy also. Okay, so know the indications and contraindications for SLNB, because that can be asked as a short note. Now coming to the radiotherapy, what are the indications for radiotherapy? It may be a primary treatment for medically inoperable patients or locally advanced disease. It may be an adjuvant treatment for high-risk pathological features such as positive margins, multiple positive nodes, extracapsular nodal spread. So extracapsular is a 3C. Okay, multiple positive nodes, positive margin, these are poor factors. So these patients will require adjuvant treatment. Even if you do the radical or partial vulvectomy, you will give the adjuvant radiotherapy to these patients. Then it may be a palliative radiotherapy for pain, bleeding, fungating lesions, etc. You may have to go for concurrent chemoradiation for indications such as locally advanced disease, unresectable tumor, and selected node positive disease. Okay, radiosensitizer is a weekly cisplatin, that is the most commonly used agent. Okay, chemotherapy has got a limited role in with this vulval cancer. As you see in cervical cancer, it has got a limited role. It is used in metastatic disease, recurrent disease, neoadjuvant settings. Okay, common drugs are cisplatin, carboplatin, and paclitaxel. Okay, so these are the different modalities and different types of operation. Okay, what we have discussed, what is removed in wide local excision, what is removed in radical local excision. Okay, now we will see the stage wise management. Okay, stage 1 we have divided into stage 1A and 1B. 1A, there are two criteria: size of the lesion less than 2 centimeter up to 2 centimeter, and invasion up to 1 millimeter. Okay, here only wide local excision is more than sufficient, even not radical. Wide local excision is more than sufficient. There is no need for the groin node surgery if your stromal invasion is less than 1 millimeter, okay, or equal to 1 millimeter. 1B, where either criteria is not certified. Either your lesion is more than 2 centimeter or depth of invasion is more than 1 millimeter, you go for radical local excision, plus you go for SLNB, groin node assessment. Okay, and if the groin node is positive, then you will decide to go ahead with the inguinofemoral lymphadenectomy, either unilaterally or bilaterally, depending upon the site of the lesion. Okay, I hope this is very clear to you. Okay, midline lesion, lateral lesion, etc. Now stage 2. Okay, stage 2, here radical local excision, or you can go ahead with the partial vulvectomy, and you will also go ahead with the groin node assessment followed by appropriate dissection, or most of these patients will require adjuvant radiotherapy also. Stage 3 is a purely nodal disease. Here concurrent chemoradiation you can decide, or you go ahead with the surgery, either partial or complete vulvectomy you can do, radical vulvectomy you can do, and groin node dissection will be required. Adjuvant radiotherapy or concurrent chemoradiation is required. Stage 4 disease. In stage 4A, where the disease is locally advanced, you have to have the individualized MDT approach, primary chemoradiation, and surgery will be in only selected patients after downstaging. Okay, stage 4B is a metastatic disease where only palliation is required. So systemic therapy, palliative radiotherapy, and base supportive care. Okay, so if you see the management algorithm, you diagnose the malignancy by doing punch biopsy, do the investigations to find out the nodal status such as CT, MRI. Then you do the FIGO staging. If it is an early disease, surgery is sufficient. Okay. Along with that, you might have to do the groin node assessment and then decide whether to do unilateral or bilateral inguinofemoral lymphadenectomy, and followed by the adjuvant radiotherapy if required. If it is a locally advanced disease, then chemoradiation plus minus surgery. And if it is a metastatic disease, then systemic therapy and palliative care. Okay. So reconstruction is required if you go ahead with the radical vulvectomy. So indications are large post-excisional defect, central lesions, and extensive vulvectomy. If it is done, you will have to go ahead with the reconstruction. Method, it may be primary closure or local advancement flaps or rotation flaps or myocutaneous flaps. You just should remember just names, that is more than sufficient. Okay. So from examination point of view, surgery is the primary treatment for early vulvar cancer. Lymph node status is the single most important prognostic factor. Tumor less than or equal to 1 millimeter stromal invasion generally do not require groin node surgery. Sentinel lymph node biopsy is preferred in carefully selected early stage patients. Midline lesions require bilateral groin assessment. Modern management emphasizes organ preservation without compromising the oncological safety. Okay, so now we will discuss about the stage-wise management of the carcinoma of vulva. Okay, so this is the stage-wise FIGO stage. Okay, when you are dealing with stage 1A. Now, what are the stage 1A criteria? Lesion size less than or equal to 2 centimeter, in depth of invasion less than or equal to 1 millimeter. Both should be present. Okay, so that is the stage 1A. Okay, and nodes are negative. Here, wide local excision or radical local excision with adequate margin. Groin node management, no groin node assessment is also required. Then you don't have to do any assessment. Usually no adjuvant treatment if completely excised and has got a favorable pathology. Okay, so stage 1A, only wide local excision is more than sufficient, no groin node and no adjuvant. Okay, now we will go for stage 1B, where the either the tumor size is more than centimeter or invasion is more than 1 millimeter. Here you have to go for radical local excision, which is preferred, and you will have to go ahead with the groin assessment. Okay, you do first sentinel lymph node biopsy, and then you decide about the inguinofemoral lymphadenectomy and radiotherapy if indicated, particularly if the margin is positive or if the nodes are detected. Okay. Then stage 2. Okay. Stage 2 is a disease in which any size of the tumor, but lower 1/3 of the perineal structures are involved. That is the stage 2. Here, radical local excision, if adequate clearance is possible, or you go for partial vulvectomy, it may be required. So radical local excision is also option, or the partial vulvectomy, depending upon the site of this tumor, depending upon the size of the tumor, you have to decide. But definitely groin assessment will be required. Okay. And adjuvant radiotherapy if indicated by margins, nodal or pathological risk factors. Okay. Then stage 3 is a nodal disease. So strong indication for radiotherapy here. Okay, because you are dealing with the nodal disease. So stage 3A, where upper adjacent perineal structures are involved. Okay. Uh, Here, stage 3 is a nodal disease. Nodal disease with the size of the lesion, size of the mets is less than 5 mm here, either one node or 1 to 2 nodes. Okay. If single node more than 5 mm is also 3A. Two lymph nodes less than 5 mm is also 3A. Okay. So here surgery if resectable, you go ahead with the radical local excision or appropriate vulval resection you do, but you will have to go ahead with the inguinofemoral nodal management. So generally here lymphadenectomy is required. Okay. And post-operatively you will do radiotherapy. Okay. Stage 3B. Here in stage 3B, again it is a nodal disease. And what happens here? The number of, there is no extracapsular spread, but the involvement of the lymph node is more than 2. Okay. Then surgery if resectable, otherwise considered primary chemoradiotherapy, usually inguinofemoral lymphadenectomy when surgical management is undertaken, and strong indication for radiotherapy. Okay. Then stage 3, here there is an extracapsular spread. Okay. Surgery if resectable, or otherwise you go for primary chemoradiation. Okay. Appropriate groin treatment when surgery is performed, and postoperatively will go for radiotherapy or concurrent radio sensitizing chemotherapy. Okay. Now you have stage 4A and 4B. 4A where there are fixed ulcerated nodes. Okay. Or involvement of the upper 2/3 of the perineal structure. So you will have to involve the MDT approach. Surgery only if it is resectable. Okay. Because surgery may not be possible, and lymph node management as indicated as appropriate, but here mainstay will be the radiotherapy. Okay. Stage 4B, here there are distant mets, so systemic and palliative treatment is individualized, and chemotherapy and systemic therapy is required. Okay. Now let us see the rapid revision. So carcinoma vulva, commonest histology is a squamous cell carcinoma. Commonest symptom is a pruritus vulvi. Diagnosis by punch or incisional biopsy. Commonest route of spread is a lymphatics. First node involvement is a superficial inguinal lymph nodes. Most important prognostic factor is the inguinofemoral lymph node status. Early disease, go ahead with the surgery. Tumor less than 1 mm stromal invasion, no groin node surgery. Midline lesion, bilateral groin node assessment. Sentinel lymph node biopsy. For that, all criteria should be fulfilled. It should be unifocal tumor, less than 4 cm, clinically node negative. Common late complication is lymphadenema, and follow-up that is common 3 monthly for 2 years, 6 monthly till 5 years, and then annually. Okay, so that finishes the topic of CA vulva. Thank you.